Hello, everyone. Welcome back. We are coming up on our last plenary of the day, and that will be given by Dr. Kate Comtois. She will be discussing the discussing science to practice in suicide prevention. Dr. Comtois is a professor and a clinical psychologist at the University of Washington in the Department of Psychiatry and Behavioral Sciences. And her career has been dedicated to promoting the recovery of individuals experiencing suicidal thoughts and the effectiveness and resilience of the clinical staff and families who care for them. This is the focus of her clinical work and training, as well as her health services, treatment development, and her clinical trials. Dr. Comtois has over 25 years experience in dialectical behavioral therapy and implementing that service in large health systems. She founded the Society for Implementation Research Collaboration, a leading implementation science organization, and is the director of the Dissemination and Implementation Core of the Military Suicide Research Foundation. We're really glad that she's able to join us today and talk more about changing services and implementing new forms of care to improve suicide-related outcomes. As a reminder, we pre-recorded all plenary sessions to limit any technical difficulties, and Dr. Comtois will be taking questions after completion of the presentation, and we'll go over those live and in real time. So please join me in welcoming Dr. Comtois.
Thanks, Mark. So I have been asked to talk about science to practice in suicide prevention. This is really the core of the work that I've done over the last 25 years. I started over in the kind of clinical science realm, working with Marsh Linehan on her earlier trials of dialectical behavior therapy. And I've moved more and more in the practice direction over the years, moving into effectiveness research, and then most recently into implementation research. What I'm going to cover today is I'm going to start off with a brief discussion of dialectical tensions that we see in how clinical suicide care is provided and the research implications. Then I'm going to spend some time on thinking about some key concepts and models between moving back and forth, up and down between clinical research, services research, and implementation science. And then I'm going to give a few examples from our work in the Center for Suicide Prevention and Recovery. So let's talk about some dialectical tension. So I come from a DBT background, and so I think a lot in terms of the dialectical tensions of different perspectives that are kind of opposites. I won't spend so much time on syntheses in this talk, but we can talk about that in the Q&A if you have questions or comments on that. So one tension that we see is the idea of where does suicide prevention belong? So there's a strong argument for suicide prevention as a matter of public health. Since a lot of folks don't receive healthcare before they attempt suicide, or if they receive healthcare, don't tell anybody that they are considering suicide, it's probably not the case that by changing healthcare, we're going to stop suicide as a problem. The needle is probably going to move from public health. And I think that it's very important to recognize that the social determinants of health and the social determinants specifically of suicide, that needs societal changes. And that's really where the change is going to happen. By contrast, you can make also an argument that suicide prevention is a matter for healthcare. It is our job, after all, in healthcare to help people who are suicidal, especially behavioral healthcare. And we tell people to reach out. We ask them to come to us. And so it's very important that we offer real help to them. That's not just a Band-Aid, doesn't make it worse, but instead helps them recover. So I think of suicide prevention in healthcare as in all of healthcare, that we should offer a cure, or at least some kind of effective rehabilitation. And it's our job in suicide clinical science to get as close to this goal as we can. Another tension is sort of the tension around kind of a risk management perspective, which is also really kind of comes down to the perspective of suicide loss. The sort of questions of, are you doing everything to prevent person from killing themselves? This idea that mental health is responsible, and why didn't we take more actions to save someone's life? Have we done everything we could? And this tends to lead to a health system response of clinicians becoming pretty focused on justification of their actions. So a very big focus on risk assessment, which can use up time in which someone could intervene and focus more on treatment and recovery, and also leads to a lot more attempts to control the suicidal person, which is where we see a lot of folks referring to the emergency room referring to the hospital. The other perspective, which comes from kind of more my tradition coming up through DBT, is the lived experience or the attempt survivor perspective, right? Where the question really is, why should I stay alive? All the pain and suffering that I am going through. And that perspective tends to lead toward a health system response focused on hearing the patient, connecting with the patient, and helping the patient change what they need to change and accept what they need to accept, moving toward a goal of life worth living and suicidality resolution. And that's a lot of what we see in DBT, cognitive therapy, caring contacts, other kinds of evidence-based practice perspectives, and quite different from what you often see in primary care and other specialty care settings. Another tension is this tension about making everything small, simple, practical, scalable. At one of our recent implementation conferences, we used this good, cheap, fast metaphor for the struggle that we're kind of facing in trying to figure out how to make interventions that are scalable. But I think there's also another side of that dialectic, that the evidence tends to be for psychotherapy, as we can see in an increasing number of meta-analyses. And suicide is behavioral health mortality. It is the heart attack. It is the cancer death. And so it is always important to ask the question, why can't the costs be as high as what we do to prevent a cardiac or cancer death? They're really not at all on the same scale. And we do spend a lot on higher levels of care, like hospitalization, when there is evidence, even for the highest risk folks, that smaller and outpatient interventions are feasible, and that if those monies could be moved into that realm, would provide a lot more funding than currently exists. Another tension is this really wonderful thing that we now have so much more suicide clinical research. To do this talk, I looked at over 25 meta-analyses. I mean, that's amazing. 10 years ago, this would not be true. So I would like, for those of you who are suicide clinical researchers, to take a moment to say, we did it. Like, this is just an amazing amount of work. And I'm excited that there is so much research out there now. And when we look at numbers needed to treat, these are some common suicide interventions in terms of numbers needed to treat with suicide attempt as an outcome. We're seeing things that are very comparable to other treatments that are regularly recommended in clinical trials. At the same time, the other side of this dialectic is there's very little suicide prevention research. If you put it on the scale of other fields like cardiovascular health or substance abuse and prevention, you can see what the numbers of deaths are in these fields and the relative NIH expenditures in 2020. So I put them all on the scale of millions, but essentially, that means that there's about $2.5 billion being spent per year in these other areas and 186 million in our field. And to give credit where it's due, it is important to recognize that has come up a lot. It was looking at 70 million back in 2015, and it's going up. So it absolutely is increasing, but by a measure of scale, it is very small. So with those kind of tensions in the back of our minds, let's sort of think about some models and concepts that kind of bridge the clinical services and implementation research. So many people are familiar with the pipeline kind of idea, where we've got our clinical research over here in the efficacy studies. As I said, this is where I started in working with Marcia Linehan in the psychology department, doing efficacy studies of dialectical behavior therapy. But I was working part-time with her, but my main basis is Harborview Medical Center, which is the county hospital in Seattle, and the community mental health center attached to that. And so all of my work was kind of in the existing Medicaid, Medicare safety net hospital. And so I did a K award in this services area of what actually is happening for people who tell people in the system that they're suicidal. And what are trials that we can run in these existing clinical systems? And that's what I've done for most of my career. But the last decade, I've been moving from these effectiveness studies into implementation research, where instead of studying clinical outcomes like moving suicide attempt needles or the suicide ideation needle, in implementation research, the goal is, did the treatment that you were looking at, let's just keep the DBT example, did DBT actually arrive where it belongs? So it's no longer asking a clinical question about what's happening with a client. It's asking a systemic question about whether DBT does or does not exist in the system. And then you've been hearing lots and lots about hybrid trials. So let's just talk a little bit about what hybrid trials exactly are and which ones you might want to be doing to find that bridge point between the effectiveness and implementation fields. So there's 3 types of hybrid implementation trials. The first is what we've called a type 1 trial. This is primarily an effectiveness trial that brings in a lot more information about the implementation outcomes as a matter of observation. So to me, this is really where everybody ought to be doing their work so that we can get as much implementation data as we can from every trial that we do. And the next one is the hybrid 2. So this is where you're simultaneously testing a clinical intervention and an implementation strategy. If we stayed with our DBT example, it might be the effectiveness study is DBT skills alone versus all of DBT, and seeing if that changes suicide attempts or suicide ideation as the outcome. The implementation strategy might be that we're measuring DBT in that system with training and consultation and observation of video versus training and consultation without observation of video. And then the question for that is, how much are people doing DBT correctly? And how much does DBT get implemented in the system? Not that many people are doing type 2 trials. You can imagine the scale and expense involved. Hybrid 3 trials, however, I think are being used quite a bit. This is where you are just testing the implementation strategy as your primary focus, in this case, DBT training and consultation with and without observation of sessions. And the outcome is, how much does DBT get implemented? But you're measuring the clinical outcomes along the way. So you might be using administrative data to, like if you were doing something in the Department of Defense, they have the suicide event reporting. So you might use the suicide event reporting as your outcome instead of actually collecting data from participants. Another model that I think is very helpful is to think about Proctor et al.'s conceptual distinctions between implementation outcomes, service outcomes, and client outcomes. So the idea here is that the client outcomes are actually at the end of the line, and the services outcome, they're dependent on services outcomes, which is essentially the IOM crossing the quality chasm set of kind of principles of good quality service. And then those services can't happen if you didn't actually implement the intervention. So this kind of turning your mind to the idea of how much your client outcomes are actually dependent on the service outcomes and the implementation outcomes, I think is really helpful in recognizing why more interventions are not getting implemented. So just to think about these implementation outcomes, I think it's helpful because you, as I'm saying these, think about it from a hybrid one point of view. What could you actually be measuring in clinical and services research? So acceptability. Does this EBP make sense? Do the stakeholders like it? Just in general, do they think it's a good idea? DBT, for instance, has very high acceptability. Appropriateness. Does this EBP make sense here in this particular setting? DBT often struggles for appropriateness because people love DBT, but just wouldn't work here. Adoption, did the system actually, are systems adopting DBT? So that's actually been pretty high. Feasibility, that's of course more of a struggle for DBT. It's a big treatment, it requires infrastructure change. Fidelity, so this is something we're all very familiar with. Are people doing it fully and correctly? Reach and penetration is like the brass ring. This is what you're after with implementation research, is that the percentage of people you trained are actually doing it is one way of measuring it. The other is the percentage of clients who need it. So in this case, the question, let's say clients who screen as having suicidality, what percentage of them are receiving, let's say, a safety plan or cognitive therapy or DBT? Cost, what does it cost to offer this EBP? And what does it cost to implement the EBP? Because there's a lot of front-end costs to get a new intervention in place that disappear once the training and the implementation's complete. And sustainability, right? How long has it been in use? Is it sticking around? Is it sticking around with enough of its key components? So these are really useful concepts, and you can really integrate these into clinical and effectiveness studies. Another model that I think is a little more parsimonious, a lot of folks use for thinking this through, is the ream model. So this is kind of narrowing the focus to reach adoption, implementation, which is mostly fidelity, maintenance, which is sustainability, and also brings in the clinical piece in terms of effectiveness. And there's a nice ream website that I've got listed there that you can use to get a lot of tools for measuring the ream concepts that make doing this more easier to do. I'd just like to highlight that Sara Landis did a really terrific webinar. So if this is something you'd like to take a deeper dive into, I recommend this webinar. It's about an hour, and she uses her research in caring contacts as an example to illustrate the point, so that it's a very nice orientation from a suicide prevention perspective. One of the things that you also need to be thinking about, not only in terms of how are you actually going to implement or put out data that allows other people to implement key clinical interventions, you've got to be able to present the research in a way that decision makers can actually use it. So you need to be able to succinctly and clearly describe the intervention. You've got to be able to show those clinical outcomes, but you also need to succinctly present the implementation outcomes and implementation resources that you've got put together. And I think it's useful to sort of think about these as kind of orthogonal dynamics. There are clinical interventions with excellent clinical outcomes who've done nothing to examine implementation. We've got folks who are getting things implemented way ahead of the data. So these are useful to think of as independent. We at the, I'm the director for implementation at the Military Suicide Research Consortium. And this is the model we have adopted, is the CDC's Continuum of Evidence model. It's an excellent way to present research that kind of puts all the different studies on the same playing field and really helps illustrate what's ready for implementation. So these upper categories really are focused on the quality of the clinical outcomes, the quality of the research that can support the clinical outcomes, replication, and then these lower items really are focused on, is there implementation resources available? Is it ecologically valid study? So I highly recommend this. And I think it's something that you can do even as you're writing your grant proposal. And it's something that we've, in a recent paper, we've recommended actually for grant funding agencies to consider asking people to be able to put their study in this larger context so that the reviewers can think in terms of how ready will this be for the next step. Another thing that's really helpful and an even bigger jump in my experience for clinical researchers is from implementation to dissemination. So implementation, right, we're talking about the efforts that are designed to get the EBP into routine and sustained use in the settings in which you want it to happen. Dissemination, however, is that process of even getting people to engage and use the information that the EBP exists. So it's that first step. You have to have dissemination to get to implementation. But it's a really different thing to think about how you're going to tailor information about EBPs for the target audience who could then move forward to disseminate. Ross Brownson and his colleagues have done really excellent work in this area. Highly recommend their article, Getting the Word Out, New Approaches to Disseminating Public Health Science. So this is a kind of model of dissemination to think about. So the question is, first of all, what's the message, right? So this is perhaps that you have a new evidence-based practice that is effective. And then you want to think kind of who's the source of that message? Who do we want to be telling this story? And who is the audience? Is this researchers presenting their message at a conference presentation to other researchers? Is this researchers presenting a public health briefing to military leadership? You can tell they do a lot of work in the military, right? And then what's the channel? How is that message actually being presented? Is this a briefing? Is this a blog? Is this a public service announcement? What is the channel that's bringing this message across? And they have a nice example of thinking about who policymakers are and what the different kind of ways you're going to want to think about this process, right? Between the executive branch, right? So this would be the public health director. This would be the mayor, the governor. What is their take? What do you want? How do you need the message to be for them versus for a congressperson or your council member, who's the elected official themselves versus their staff member, right? So their staff member is going to be hearing a very different message, and you're going to have to sort of tailor that message differently. So let me give you a couple of examples of different ways that this pathway has happened in research that I've done and others at our center. So like I said, I've been using this example of DBT. That's been a pretty traditional process. So DBT was developed in a psychology department at a university here, actually at UW, and preliminary research was done in comparison to treatment as usual, followed by component research, looking at the internal validity control group, then comparison of different models, the full DBT model to skills alone, individual therapy, and then more recently, people have been studying components by themselves, like group skills training only. Then we have the implementation and adaptation, and that's happened largely outside of research. So the treatment developer, Marsha Linehan, has been involved in a lot of this. There's been some adaptation done with research, for instance, in the area of substance abuse and eating disorders, but there's been many, many adaptations, like for inpatient units and residential units, that's been done entirely outside of the research field. There's really been some pretty limited implementation science work, mostly by Sara Landis, again, who has done very interesting research studying the implementation of DBT across the VA. So this is an intervention that has had no systemic VA funding, like prolonged exposure or cognitive processing therapy or CBT, which has had rollouts within the VA. So she was studying the natural process in which DBT is disseminated and what have the barriers and facilitators been. And what we see is that DBT has been successfully implemented, in part because it's pretty effective. And also there's a real pull because of the cost savings. So because the DBT is focused on people with chronic use of high levels of care, like inpatient units, and it's an outpatient program, then you see these cost savings. And so systems want DBT to come and get people pay for training, et cetera. But it does mean that DBT is very dependent on systems with cost savings. In the absence of cost savings, it's pretty hard to sustain DBT programs or even get them implemented, such as in the Department of Defense, which pretty much doesn't use DBT at all because there's not a real cost savings, and most folks with that kind of chronic illness are separated from the military. So let me give you a contrasting example. So preventing addiction-related suicide, or PARS, is an intervention developed by my colleague, Rick Reese, and it got funded in its actual setting, which is intensive outpatient programs, which are group-based outpatient drug addiction programs that are the standard nationally for how most people receive drug and alcohol treatment. And he had a good idea to develop this based on some of the secondary prevention work that you see in schools like SOS. And based on that, he was able to get R21 funding. He put an advisory group together of agency leaders and experts, and and I was one of the experts in that. And we developed the intervention. And as Rick likes to tell the story, he had this vision that this would be a 2 or 3 sessions. IOPs have 24 sessions, each about anywhere from 90 minutes to 2.5 hours each, didactic and discussion. And he thought he'd have maybe 3 or so of those. And they said, no, you can have 1. He's like, no, we should be able, no, you can have one session. We have so many rules and regulations about what those 24 sessions have to be. You can have 1. And so that's what he developed, an intervention that happens in a single session. He did consultation with IOP clinicians, and then he piloted in IOPs. And then we subsequently applied for and received funding from NIDA to do a stepped wedge cluster randomized trial in the actual IOPs across Western Washington. Recently finished that. You can see that we had positive outcomes, which was really terrific. And along the way, lots of other funded opportunities have come along. So we've got a supplement where we're doing an adaptation for Alaska Native and American Indian treatment centers. There's been McLean has been funding a adaptation for first responders. There's a modification with funding to test it for veterans. And we're currently waiting on an adaptation for opiate overdose as well as suicide prevention. And he has also been able, Rick has been able to get some funding to develop his training materials and his website. So this is an example where the entire process was funded by research. And lastly, take a look at caring context. So caring context is a tiny intervention, but it has not naturally gotten disseminated, which is kind of ironic because DBT is ginormous comparatively and has been widely implemented. So I think most folks know about caring context, right? It's developed in the 60s. The initial data is presented in 1976. And then it's crickets. Marsha Linehan, when I was first working with her in the 90s, was pushing Jiro Amato, who developed the treatment, to publish the long-term data, publish it. He finally does in 2000. And that does spur some other trials. These are some examples of some of the larger positive trials of caring contacts, how often, the type of card that was sent or text message in our case, the schedule, sample, and the outcomes. So, it has not naturally been picked up. So it's been done in research, but we see a lot of people wanting to do it and then not actually moving forward with it. So Mark Rieger and his colleagues took one approach, which was to examine it through a series of studies with veterans and looking at using administrative support to actually do the logistics of the caring context to see if that would increase the provider's use of them. And the VA has now started to seriously pull. So they have scaled up a large study, very, very large study. I think there's more than 90,000 in there now. And then now research and program evaluation that Mark is doing is following that. By contrast, Sara Landis has taken a traditional implementation science approach. So she has been conducting a study of the implementation strategy of an implementation toolkit and facilitation. Facilitation is a evidence-based implementation strategy for getting a wide range of medical and behavioral health interventions implemented in large systems. And of course, the interventions carrying contacts. So she got funding through the VA query system, where they partner with the actual working sections of the VA. You, as a researcher, partner with the system to get things implemented and to evaluate them. So she did a pilot using this testing this facilitation model that included building a really wonderful toolkit that is available for people who are interested in doing caring contacts. So one of the negative studies of caring contacts was actually in an ER. So Sara was really thoughtful about what needed to happen to get this to be a successful process in the ER with her partnership with her ER colleagues in Arkansas, and really thinking through each of these different issues in the implementation of caring contacts. This is an example of a card that they developed, very thoughtful. What should the greeting be, right? Mr. Smith, what should the message be, right? And adapting what the message is to the emergency room. Who should the author be? In this case, the nurse manager and the ER department team. How should people be able to get back? In this case, a phone number, and also there is an address. So each of these things was carefully thought through. And then it was implemented, and they did a pilot. The results have just come out in a paper we've submitted. So you can see using this as an example, mostly just to show you how ream can be used. So she organized her results based on the ream concepts, and you can see what that kind of data looks like. And now, based on that positive data, she has expanded out to 28 studies. So now it's a much larger hybrid 3 trial where they're going to have a bigger sample and ability to examine suicide outcomes in more detail than just service utilization. And lastly, I just want to highlight an example that we have been working with in terms of dissemination issues in caring contacts via text message. So the Center for Suicide Prevention and Recovery did a study with the military using text messaging caring contacts. And in text messaging, you get a lot of replies. So 69% replied. And at the same time, very, very low rate of replies that required immediate response. So that really has left us with an implementation question of when and how to send and respond to text, manage the risk management with that. And so the approach we've taken is to partner with folks in informatics, in all of these different informatics areas, to build a informatics supported authorship of caring contacts tools. So our next step that we're waiting on funding on right now is to build a blueprint that is a set of principles that can be given to a programmer within a large system like the VA or Department of Defense or Kaiser, any of these large health systems, where they would need to program their own tool in order to work inside their firewall, as well as to build a software tool for health systems and small clinics who would not program their own software. They would need prepared software. And our goal is not only to do hybrid implementation, trial of carrying contacts implementation, but also there are folks who are interested in the mechanisms of carrying contacts, where the difficulty of kind of doing the carrying contacts part, as well as doing the measuring the mechanisms, is kind of makes it more complicated. And we hope that this would promote those kind of research. So I know I'm running over here, so I'm just going to end with a few concluding thoughts. So as we all know that clinical suicide research is time consuming, it's underfunded, and particularly for the scale that's going to be needed, I think, post-COVID, or, even now in COVID. The interventions, we do need interventions that fit the system the way the system is, that are scalable. But we also need to think about policy that would motivate and fund health systems to pay for what works and what's needed, so that we're not entirely dependent on what can be done with the budgets that exist. And that by using this kind of integration of the clinical, the services, and the implementation science, we can speed up this process. So I'm going to end here with any questions or comments. We'll move to that. If you don't get your questions or comments in and you would like to contact us, here's all of our contact information. Thank you so much.
Wonderful. And thanks so much, Dr. Comtois, for a great presentation and all the work you do in the field of suicide prevention. We have time for a few questions here. And one of the ones that I've been wondering, during this summit, we've heard about a number of intervention approaches. And you mentioned during your talk that everyone should be doing a hybrid one. And I was wondering if you could just explain a little more of the rationale for that, and why people who are thinking of doing intervention trials should think of a hybrid one, and maybe an example of what that might look like.
Sure. So the hybrid one, what we're saying is, while you do your clinical research, so this could be at an R34 level, like a treatment development study, or during a clinical trial, you can ask questions of the partners who you're working with. And even if those partners are just your graduate students, it is important to know, is it acceptable? To know how fast can you get someone to fidelity. If you are working with a partner organization, let's say a counseling center or a primary care clinic, do they want to keep your intervention going after your study is done? How much do they find themselves using that intervention with other patients outside of your study? All of those things are answering these implementation questions that the systems you would want to move to. Those are the questions they need to know, as well as your clinical outcomes, in order to go forward. So the more you can think about that consciously, plan that in your dissemination plans when you propose a study, and assess it as you go along, the more information you'll have at the back end to really help get your intervention out there.
Great. And one thing I was wondering about is, you mentioned that REACH as an implementation outcome was really the brass ring, and what you were hoping people would really be striving for. And I was wondering if you could say a little bit more about what you mean about that, and what REACH is and how people can strive for that.
Yeah, one of the things that I see regularly when I do training and implementation in DBT, I really notice how often you get an intervention, somebody pays for you to come and train that intervention, and you come back, a year later, and a few people do that intervention fairly regularly with a subset of their patients. But if you went to the clinic and you looked at how many patients let's say, had suicidal ideation, and you would find that a very small proportion of them are actually getting the evidence-based practice. And so really what your goal is when you're implementing something is that it actually gets used proportionate to the number of people who need it.
And we don't have much time, but maybe just briefly you could talk a little bit more about the process of dissemination and how someone might begin to think about that earlier on in the process of doing their research and strategize about how to do that well instead of as something that they come to at the very end of a long process.
I think the most important thing to think about is who are the partners. I think the easiest, most straightforward thing, something we've done in our trials, is to get an advisory group together who represent the folks who you would like to be interested in your intervention later. So you could do it in a traditional sort of advisory group way, have people that you meet with who have lived experience, as well as leaders who would be funding, and meet regularly right through the process, and they'll tell you what you need to know. Wonderful.
Thanks so much. We are actually right up against the 5 o'clock hour here Eastern time. So we are going to switch over here to getting some concluding comments from Dr. Cheryl King. Cheryl?
Thank you, Mark. Now, on behalf of our Injury Prevention Center and our Summit Planning team, thanks to all our presenters, your research moves the field of suicide prevention forward. It'll contribute to keeping our communities healthier and safer. We would also like to thank all of our facilitators and our Injury Center staff for organizing this conference, especially Jessica Roche and Sonia Kamat. They have been truly amazing with managing all of the communications and details that are inherent in conference planning. And I'd like to thank all of you, all of our attendees. I hope you learned from and enjoyed this conference. Now, some additional important information before we close. Recordings of all sessions will be uploaded to our website in the coming weeks. If you're not already a member of our Injury Prevention Center, we invite you to go to our website at injurycenter.umich.edu to become a member and get access to our monthly newsletter with publications, updates, and events. As a reminder, we'll be sending out an evaluation shortly after the event, so please let us know what worked, what you think we could improve upon for our next virtual summit. For those of you who will be requesting free continuing education credits, we have AMA PRA, Category 1, APA, Michigan Social Work, and CHES credits available. In order to claim these credit opportunities, you will need to complete the evaluation survey that we will send after the event, and instructions on how to claim the credit will be at the end of the survey. If you need a certificate of attendance, you'll also need to complete the evaluation survey that we send. And again, there'll be instructions on how to claim that certificate at the end of the survey. We also want to encourage you to attend our upcoming Ask the Expert Twitter event. It will be on Tuesday, March 30th, from 12 to 1 p.m. Eastern Daylight Time in the U.S., where we will be reviewing some of the questions that came in during this event. Additional information can be found on our website, which is linked in the reception tab, and any questions you have about the summit can be sent to uminjurycenter@umich.edu. Take care, everyone, and thanks again for joining us today.